Coming up next on Being Well, a subject important to women of all ages, and that's breast cancer. My guest this week is Dr. Abdur Skakir, Director of the Sarah Bush Lincoln Regional Cancer Center. Dr. Skakir will discuss risk factors and prevention strategies. In addition, we'll learn more about the latest advancements in breast cancer screening, surgery, and treatments. That's coming up next on Being Well, so don't go away. Dr. Skakir, thank you so much for coming on the show and talking today about breast cancer. Let's get right into it and talk about what makes the breast such a place for cancer to grow.
Sure. So normally why women develop breast cancer is that they have a lengthy period of menstrual cycles throughout their life. So by the time they have their first period, or menarche, till the time they have menopause, they're having a constant stimulation to their breast with estrogen and progesterone. This stimulation to their breast makes their breast swell, makes their breast go back down, swell and go back down. That happens every single month for a woman. That stimulation changes the architecture of the breast. When you change the architecture of the breast over a period of time, that can lead to breast cancer.
So what do you mean by architecture? Is it the tissues or what really?
Correct, the breast tissues change. So that's why the risk factors for developing breast cancer usually happens at the time of 45 to 50, meaning they've had 30 years of stimulation to their breast. So that change of architecture over that lengthy period of time, or changing those tissues, can lead to breast tumors.
Okay, you brought up risk factors, and that's something I know a lot of women want to know about. So let's get into that. Talk about the primary risk factors.
Sure. What I usually divide them into for women is these are non-modifiable risk factors that you can't change in your body, and there's modifiable risk factors. Non-modifiable risk factors are gender. And when I say gender, people look at me funny. I say, well, women have breast cancer. At around 200,000 women per year get breast cancer, but men also get breast cancer at about 2,000. So women have 100 times more likelihood of developing breast cancer than men do. So being a woman is the first risk. The second risk is age. Women between 45 and 50, and then up to 75 years old, have the increased incidence of developing breast cancer. What we also look at is the race and ethnicity. If a woman is Caucasian, they have about 124 out of 100,000 risk of developing breast cancer, versus an Asian woman that have about 80 out of 100,000. What's different for race, for African American women, is that although they have a less incidence than Caucasian women, they have a much more aggressive type of breast tumor than Caucasian women do. So they can die sooner from breast cancer than Caucasian women do. Lastly, what we look at is if someone's already had a history of breast cancer. So if someone's had a history of breast cancer, you can't change that.
Right.
Their increased risk of developing breast cancer on the opposite breast by about 1% per year. So those things you can't change in a woman. But there's also something called modifiable risk factors. And the first modifiable risk factor I always talk about with a woman is their weight. There was a large study that was out through nurses. They evaluated a whole series of nurses, about over 50,000 nurses. What they looked at was if a woman weighs more than 175 pounds versus less than 130 pounds. This is only for postmenopausal women. If a woman weighs more than 175 pounds, she has about a 25% increased risk of developing breast cancer as compared to their counterpart at 130 pounds. So weight plays a significant role in developing breast cancer for women, things that she can change. Secondly, what we look at is smoking and alcohol. So women who smoke, although there's not a lot of conclusive data that's out there, we know that smoking is related to cancer in general, especially for young women who smoke. We know that there's an increased risk of breast cancer. So if you're overweight and you're a smoker, you need to stop. But one of the other common risk factors that we think about is alcohol. There's been at least over 40 different studies looking at alcohol in relation to breast cancer. What they found out is that women who drink more than 3 drinks of alcohol per day increase their risk of breast cancer anywhere between 10 to 20%. So what we do tell women is that if you're overweight, you're a smoker, and you're a drinker, those are things that you can change in your body to decrease your risk of breast cancer.
Okay. Let's talk about family history, because I know that's a concern for a lot of women.
Sure. So family history, when we really think about breast cancer, accounts for about 15% of breast cancer. So really not a whole lot. So 85% of other women are developing breast cancer without family history. When we look at family history, if you have a mother with breast cancer, if you have a sister with breast cancer, if you have a daughter with breast cancer, Those are first-degree relatives. When you have a first-degree relatives, that doubles your risk of developing breast cancer. Now, if you had a mother and a sister with breast cancer, that triples your risk with developing breast cancer. Or if you had a mother that was less than 30 and developed breast cancer, that triples your risk as well. So if you had a mother, a sister, and that were less than 30, your risks are pretty exponential. They're going up. So family history is quite important, not just for the oncologist, but your family doctor who's going to be doing the screening test on you. So if he knows that, hey, my mother had breast cancer at 35 years old, he's going to be evaluating you by the time you're 25 to make sure things are going okay.
Okay, let's talk about screening. You know, we had heard for years, you know, a mammogram every year after 40, and then some things came out that said, no, you don't need that, and it's very confusing. What are you recommending for women?
So there's going to be a caveat to what I'm going to say.
Okay.
Our philosophy at the Sarah Bush Lincoln Cancer Center is threefold. The U.S. Preventative Task Force in 2009 came out and said mammograms should be done for women above 50 and older. These were a panel of experts that came out and made this recommendation. They not only said women over 50, but what they also said was that women over 75 should not have mammograms. They also said that women should not be taught to do self-breast exams. They also said that women less than 50, unless they have family risk factors, should not be having mammograms. And like I mentioned, only 10 to 15% of women have that family history. So we take a different approach. We take actually a three-tiered approach. That 3 tiers come from Mayo Clinic. What we say is, we tell a woman, if you are examining your breast, you should be doing that on a every 1 to 2 month basis, being familiar with your breast tissue. And this should start at the time you're 40 at the least. You should have a breast exam by a healthcare provider every single year after the age of 40. And we recommend mammograms after the age of 40. And we made this 3-tiered approach based on a Swedish study that looked at 1 million women. And what they found from this 1 million women was that if you start screening them after the age of 40, you decrease the risk of breast cancer death by 29%. That's significant in my mind. And I've seen enough patients to know that breast cancer can happen in the 40s, breast cancer can happen in the 30s. And like I explained also before, with age, we see the incidence of breast cancer shoot up at the age of 45. So we need to catch women before the age of 45, not 50.
Why does it go up at 45?
I think mainly what happens is that's their menopausal state typically. So that between 45 and 50, that's when women develop menopause. And that's their longest time of exposure to their menstrual cycles as well.
It seems like estrogen plays a significant role in breast cancer. The reason why estrogen plays a significant role is twofold. We know this by if your body produces estrogen or if you're taking estrogen. So from women in 2002, there were women that were promoted to say, take estrogen. If you're postmenopausal, if you take estrogen, it's going to help your heart, it's going to help your bones, you're going to feel great. What we found out in 2002, that wasn't true. What they found in 2002 was that there was this huge rise of breast cancer. They said, well, what happened? What they correlated that with is women who are postmenopausal taking this estrogen supplements. Now, there is a strong debate on how true that is and how significant that is. My opinion is that if a woman is menopausal, they should not be on any form of estrogen. Because there's a clear-cut reason why women develop breast cancer, and that's estrogen stimulation to their body. Let's talk a little bit about, we've talked about risk factors, family history. Are there things that we can do now in terms of our diet and exercise that can help lessen our risk for getting breast cancer? Absolutely.
So there is a large study that's going on by the National Cancer Institute as well as Stanford to look at how do we tell women what to eat to prevent cancer in general, not just breast cancer, but cancer in general. They have done a series of studies. Nothing's very conclusively yet. But there's 3 main groups that they're looking at. The first type of foods that they're looking at is something called phytochemicals. This is a chemical substance that's produced by plants. They use this to fight against bacteria, funguses, and viruses in the body. What they find out is that these phytochemicals can help hopefully prevent cancers, not just breast cancer alone. These phytochemicals are found in certain fruits and vegetables, usually the bright colored fruits and vegetables like green ones, red ones, orange ones. And the National Cancer Institute is looking at these to see how much this can help women. Now, I don't go out and say this is going to help you prevent cancer. But what I would tell women, I always tell this to women, is that I know this can't hurt you, but I can't tell you how much it's going to help you. So you have to take some of these data with a grain of salt. What we also know is something called antioxidants. We always hear about antioxidants in cancer. What you have to understand is how antioxidants work. What they do is that they stop the free radicals that work in our body. What free radicals are a process that are an end process in our body that when we break up materials, that's how free radicals develop. What free radicals do is that they go and attack normal DNA in our body, and those allow tumors to grow. So there's a bunch of foods that have antioxidants in it: vitamin C, selenium, blueberries, blackberries, all these other fruits that have antioxidants in them. I always tell women, yes, again, they may help you, but I can't tell you they'll probably not hurt you. But there is some data that's still ongoing with antioxidants. We do not recommend the taking of antioxidants when you're on radiation therapy.
Okay.
But to hopefully prevent cancer, they may help along the way. The data just isn't there yet. Lastly is omega-3 fatty acids. There is some data out there that says that can help with breast cancer and colon cancer. Again, the data is not conclusive. So yes, I think women can take some steps of how do I do fresh fruits and vegetables and grains and cereals, but that not only will help cancer prevention, will also help heart disease, obesity, diabetes as well.
That's right. That's all things that we need to do for a healthy diet anyway.
Correct.
Let's talk, you had mentioned there are different types of breast cancer, different grades, and that can be confusing because that sort of, as I understand, sort of drives the treatment. Can you explain the different types and grades? Sure.
So when we see a breast cancer patient, the first thing that happens is usually a biopsy. After a biopsy is done, our pathologist looks at that tissue under the microscope, and sometimes I do as well, and they make a point to say, this is the type of breast cancer that the woman has. And that really drives what type of treatment we do. So there's certain types of breast cancer that are very low grade, something called ductal carcinoma in situ. These type of cancers, or low grade type of tumors, are usually treated with just surgery and radiation and sometimes anti-estrogen therapy alone, and not very commonly with chemotherapy. We have a different grade, something called infiltrating ductal carcinoma, which is the higher grade type of breast cancer, that not only do we do just surgery, radiation, but sometimes we also offer chemotherapy as well. So when a woman goes and sees their oncologist or even their family doctor or surgeon, you should ask, what type of breast cancer do I have? Is this a low-grade breast cancer? Is this a high-grade breast cancer? And that will dictate treatment.
Okay. Let's talk about the doctor team. That can be intimidating, very confusing if you are diagnosed. There's this whole group of people, everyone plays a different role. Can you kind of explain how you work as a doctor team, and how does the patient sort of digest all that and, deal with all these opinions that you might be getting? Sure.
So what I always recommend to women is that once they get a diagnosis of cancer, or even a man with cancer, once they get a diagnosis with cancer, is that you should look towards your oncologist to be kind of the ringleader, to say, what do we do next? You're going to have surgeons involved, radiologists involved, radiation oncologists involved, family doctors involved. But I think the final opinion, what to do next for somebody's cancer, should be relied on their oncologist. So you have to develop the rapport and hopefully the relationship with your oncologist that you could ask him anything and be able to spend time with him to say, this is what we should do for your type of cancer.
Okay. And what advice do you have for family members who, how can you help, advice for them to cope with their loved one who has breast cancer?
The thing I always recommend for all our new patients that come to the Sarah Bush Lincoln Cancer Center is that bring your family members or friends with you, not just for support, but as a recording secretary, as another set of ears, as a question asker. The reason why that's important is because when you go home as a cancer patient, there's a flood of information that's thrown towards you. And you may not be able to comprehend everything what's going on, but if you have close family members that are in the room with you, they're able to at least put things into perspective. The thing I always tell people that come alone, and they may not have a close family, is that you should absorb the information I tell you and go back home and then come back again, and we'll do it all over again. And we'll explain the things from the top all over again. And I always tell people that they should relay information to close family friends and family members, simply because you tend to have people ask a lot of questions, and that frustrates a person. What are you doing? Are you really doing this? Or is that's not what my doctor told me to do, and that puts anxiety on a person. So I think it's really important that you relay information in probably small groups of people that you know closely, and little information, So then they might not ask you so many questions. You'll know who to give that information to. Obviously, parents and sisters and even children, those people will probably absorb most of the information versus friends that may ask you kind of pestering questions sometimes of why you're doing this.
So how do you as a doctor decide with patients, okay, this person needs a mastectomy, this person needs a lumpectomy? What are the criteria for that? Sure.
This is an excellent question because we get this very commonly. How do I choose to have a part of my breast removed versus my whole breast removed? There are some pros to cons to both.
Okay.
With a mastectomy, it is removing the whole breast tissue, so there will be no breast left. Versus a lumpectomy, you're removing basically a small portion of the breast tissue and conserving the breast that's there. With a mastectomy, it is a more detailed procedure, so not only will you have to have that surgery that day, not only will you have to have general anesthesia that day, you'll have to stay in the hospital that day. The pros with the mastectomy is that you don't have to typically go under radiation therapy for 6 to 7 weeks. With a lumpectomy, what we know is that you can do the lumpectomy, but you'll have to do the radiation for 6 to 7 weeks. The main question a woman should always ask me is that, well, what's better for my breast cancer? Forget the aesthetics look. Forget me doing radiation. Is there something that's better for my breast cancer, the mastectomy or the lumpectomy plus radiation? There has been enough clinical trials that are out there that tell us that they're fairly equal. There may be some that says mastectomy decreases the risk of recurrence rate by slightly bit more, but when you look at the statistics, they're identical the same. So if a woman comes in and says, I don't want to do radiation because I'm traveling, I'm working, I can't sit here for 6 to 7 weeks coming Monday through Friday, then I say mastectomy is a reasonable option for you. If a woman says, I want to conserve my breast, it makes me feel good, then I say lumpectomy and do radiation. So there's not a better way for treating your breast cancer, it's more of a personalized approach. What would you like to do?
When typically, if a woman does have a mastectomy, I'm sure a lot of them say, when can I have reconstruction done?
Sure. That really depends on two things. How well you've healed from your mastectomy. Sometimes you can do the mastectomy and the reconstruction at the exact same time as well. So reconstructive is still a good way of doing things. The issue with reconstruction from a cancer standpoint is that when they put in implants, we can't evaluate the chest wall anymore. So when the implants are there, we can't tell if any recurrence of the breast cancer is happening where they did the incision before. So we sometimes have to offer MRIs to take a look at the chest wall to make sure the chest wall looks okay.
Now go ahead, sorry.
That's about it.
Now you mentioned mastectomy and radiation. Do you do chemotherapy for breast cancer?
It depends on a bunch of different factors. So anytime I see a breast cancer patient, I say, we're going to be looking at certain things. First thing I look at is what's the size of the tumor. If the tumor is more than 1 centimeter, you're going to be looking at likely chemotherapy. If the tumors have lymph nodes involved, we're going to be looking at chemotherapy. If the tumor has a high grade, grade 3, then we're going to be looking at chemotherapy. If the tumor has HER2 positive, which is a marker that sits on breast cancer that makes it drive the breast cancer to grow, they're going to be looking at chemotherapy. So when a woman decides to do chemotherapy or not chemotherapy, it's a very individualized approach to this.
It's complicated.
It gets very complicated.
Thank goodness we have people like you. Let's talk about, there's always new technology and new research and new things that are coming out. Do you want to talk about some of the new treatments that are available to women out there?
Sure. I think this is a good kind of change because when we talked about who do we choose for breast cancer treatments and chemotherapy, there is a test that looks at genes in women. It's called Oncotype, and there's a sister test to that called Mammoprint. These two tests look at genes in the breast cancer. The reason why this test is so important is, as I told you, it's very complicated who gets chemotherapy and who does not. This type of gene analysis, it looks at 16 cancer genes in the body and 5 control genes in the body. And it gives the oncologist what are the risks of the breast cancer coming back if we do chemotherapy or if we don't do chemotherapy. And that's a good way of approaching a woman. I could say, listen, if we don't do anything, there's a 35% risk that breast cancer is going to come back. This type of test is now advocated and promoted by the National Comprehensive Care Network, and I usually offer it to women, but they have to fall into a certain circumstance, meaning a tumor size that's more than 1 centimeter and has no lymph nodes involved, and that's where it becomes kind of fishy of who do we do chemotherapy and who do we not. This type of test is very expensive, but it could save women from having chemotherapy, who used to have chemotherapy beforehand.
What about technology? I'm assuming that in mammograms that the technology, the resolution, and to read those has become a lot better.
Correct. So there is, what we have at our cancer center at Sarah Bush is we have a digital mammogram. Not only do we have a digital mammogram, you not just have to have a good digital mammogram, you have to have an expert radiologist reading those digital mammograms. So that's what's very important. So during that time when a woman has a mammogram, we're able to say immediately, you need to stay here. We need to do another mammogram, and we may need to do an ultrasound and a biopsy. So if a woman comes in to do a mammogram, they're going to know that day what's going to happen next if there's something fishy. So that technology of doing digital mammograms has kind of revolutionized things. We're able to pick up immediately, have a radiologist look and say, things look okay, go ahead for the next year. There's also a huge number of other tests that are available for cancer, like MRIs, like PET scans, like CAT scans. But I always warn women we should use that in individualized certain cases. Usually a woman comes and asks me, I heard my friend had a PET scan or my friend had an MRI. We want to limit their radiation exposure, so we use that in selective cases.
Okay. What about, this was a couple of years ago, the testing for the breast cancer gene. Is that still going on?
Absolutely. That test is called BRCA gene or BRCA gene. That test I offer in every single woman with less than 50 years old that develop breast cancer.
Okay.
The reason being is because if we can pick up this gene in a woman, we know that they have an increased risk of developing breast cancer on the opposite breast, and we also know they have an increased risk of developing ovarian cancer as well.
Okay.
So that gene is vitally important in checking in certain women.
And a lot of times, this happened to a friend of mine. You know, you go in for your first mammogram and they find something. Sometimes it's not, it's scary, oh, we found something. It's not always breast cancer. There are other things that can be in there, correct?
Absolutely. And part of what we mentioned before about the U.S. Preventative Task Force in 2009 saying mammograms should be after 50 is because they did report a lot of false positives. Women would have this abnormality, they would have the stress of getting a biopsy, biopsy would be negative, they'd have a repeat mammogram in 3 months or 6 months' time, have another biopsy and negative, and all those procedures take a toll on a woman, take a cost to society as well. So yes, it's frustrating. But the way I look at it is that if we can catch a woman early with breast cancer and save their life, then some of those have to be worth it. Some of those extra tests for some other women have to be worth it because maybe we've caught a 40-year-old with breast cancer. So some of those do take account, but I think the cost of lives that are saved with earlier detection is far outweighs the risk of waiting till 50.
So what is it when you, you get called back in and, oh, well, you had an abnormal mammogram. It's not cancer. Well, what is it then?
Sure. Sometimes women have dense breast tissue or something called fibroadenomas or benign tissues that are developing, and it happens for no good reason. It's maybe just a part of their normal breast tissue that's developing an abnormal benign kind of tumor that's there. So yes, it is scary, but the good thing is, what I recommend is that if you have a close follow-up with your physician, if you're having close mammograms, and you're doing self-breast exams at the same time, all that will keep account to make sure things look okay. If there's a high enough suspicion, so I get second opinions of, should we do something or should we not? If there's a high enough suspicion for me, meaning if a woman who is 45 or 50, who's a smoker, alcoholic, obese, has a family history, and has this goofy-looking abnormality on the mammogram, I'm going to say go ahead and biopsy it.
Right. Well, as we wrap things up here, why don't you, you see cancer patients all the time. Give us just some advice. If you're diagnosed, what sort of advice do you have for breast cancer patients? What
I always recommend to every single breast cancer patient is you have to have a very good relationship with your oncologist. Because this is not a marathon race, it's a journey. And you have to be able to ask your oncologist questions, have the freedom to ask him questions, and have him or her be able to reply back in an appropriate manner. So I always tell women to ask information, ask questions, have a list of questions when you come back to see me. Sometimes I have women come in and have no idea what breast cancer is about, haven't done any sort of research. So I say, let me give you all the information on breast cancer like we did here today. Then you go back home, think about it, think about some questions, write it down on a piece of paper for the next week, and then come back to see me because you need to ask me some questions about what's going to affect you. So I think asking questions to your oncologist, having the relationship with your oncologist is vitally important.
Okay. Well, thank you so much. This has been very helpful, and I think it's going to be good for women to hear this information. Lots of new things that I didn't know. So thank you so much for coming on Being Well. We appreciate it.
Thank you for having me.
Don't forget, you can watch full episodes and demonstration segments from the Being Well series.
Visit us at youtube.com/WEIUTV.